our COVID-19 because that made make us much closer. So regarding our Indian Society of Emergency and Cardiac Nurses, it's a group of nurses working for the welfare and the empowerment of nurses. So we are looking for volunteers who can be a part of active part of this team. And if you wish to be an active part of this team, you can contact us at any time. And the only condition is that you have to be a good volunteer and you have to spend your time for our profession. That's all. I don't want to take much time. Next, as Vani mentioned, today we are here because of this World Pneumonia Day webinar. The theme is Stop Pneumonia, Every Breath Counts. Okay, so our experts will be talking about that. So I don't want to speak about that also. So directly I'm going to my responsibility, that is to welcome you all. So first of all, I just want to welcome Dr. Manju Valsa ma'am. She's the former principal, College of Nursing. And we can see for some, the name itself is the definition. No need to say much more about that. And we are really, as I said, I already conveyed to them that I'm really excited to have ma'am here. And ma'am, on behalf of ISECN and personally, I welcome you for this function. Next, we are having another eminent personality, Dr. Jyoti Sireen. She's also, we can say, a big figure in nursing. She's very much experienced and talented. And definitely, you'll be coming to know much about her from Vani. She'll be telling about that. And she's presently the Dean in Nursing from College of Nursing, Mullana, Haryana. And you might be seen in many of the conferences also. So, you know this introduction, and because everyone knows about it. And ma'am, we welcome you for this World Pneumonia Day webinar. And we are having our eminent personalities or today's speakers. That is Miss Ambali Venugopal. She is the pediatric nursing officer or nursing officer working in the pediatric ward in Imce, New Delhi. And she'll be dealing the topic latest guidelines in pediatric pneumonia assessment and management. So we welcome you, ma'am. Next is our next speaker, ma'am Shakuntala Sundrial. She's the senior nursing officer working in JPNATC Ames, and she'll be dealing nurse-led screening bedside ultrasound in pneumonia. We welcome you, ma'am. And we are having a speaker from, she's having an international domain, Miss Janet Sumesh. She's a APRN, FNP, CPAN, Houston, Texas, USA. She'll be dealing with the community acquired pneumonia. She's the family nurse practitioner there. And so we definitely will be getting an opportunity to compare the management and the methodologies used in India and USA. So I request all the members to utilize this opportunity. And I would like to welcome all other members who are watching this program on YouTube and who all are blessed with this occasion. They shared our gratitude. Many people conveyed that they are not able to join because of some personal reasons. I'm welcoming everyone for this event. Thank you all. So I'm just handing over to Vani. And before that, I just want to say sorry if I left anyone, or as I said, I'm really excited. Might be I made some mistakes. So please pardon for that. Thank you. So Vani, you can take care.
Thank you, sir. Like Fahmi sir said, today I have got a great opportunity to introduce Dr. Manju Valsa. Her name itself is enough. We don't need to say anything more. She is the former principal of College of Nursing, Imce, New Delhi, and former director of National Reference Simulation Center. She has done her MSc Nursing and MPhil from RK College, Delhi, and has done her PhD in Pediatric and Neonatal Nursing from Manipal University. She also has done Commonwealth Fellowship in Medical Education Technology at University of Dundee, Scotland. She is also awarded with the President of India's Gold and Silver Medal from Delhi University and has been also awarded the Best Research in MPhil Nursing. She has nearly 45 years of experience in nursing education and research and has been a UGC assessment team member for several universities. She is even the founder president of Indian Association of Neonatal Nursing. She has been a NAC assessor and a group member for revising the NAC manual. She has also been a consultant in Ministry of Health, Government of India, WHO, BPKIHS Nepal, Government of Ethiopia, Government of Madhya Pradesh, and various projects related to nursing. She has done over 80 publications and 450 citations. She has guided 8 PhD theses and 100 of MSc nursing dissertation. And these are just a tip of icebergs, which I have not even mentioned more because it will take a lot of time. I request, ma'am, please inaugurate our webinar.
A very good evening to all. Thank you very much, Vani, for that introduction. Before I start, I would like to congratulate Mr. Shaukat Ali, Mr. Hamid for founding this society, Indian Society of Emergency and Cardiac Nurses. In fact, let me just be very honest and say that today, this is the first time I heard about the society. I believe it is just 2 years old. And Mr. Famir is the General Secretary, Shaukat Ali is the President. And I believe Dr. Poonam Joshi is the Academic Council Chair, and Vani Krishnan is the member of the Academic Council. So all the organizing committee members, participants of the webinar, I would really like to compliment the Indian Society of Emergency and Cardiac Nurses, first of all, to choose this day to have the webinar on World Pneumonia Day. The theme of the World Pneumonia Day this year is Stop Pneumonia, sorry, every birth counts. And the training of nurses on this theme is very timely and the need of the hour, particularly when at a time, I believe it is including, your webinar includes latest guidelines on pediatric pneumonia, nurse-led screening at the bedside by ultrasound, and updates in community-acquired pneumonia. I believe with I hope and pray that we don't have a third wave of COVID-19 coming, but as it was predicted that there is going to be more children involved in the third wave, if at all it comes. So very timely that you have opted to celebrate the World Pneumonia Day by doing this webinar. As it has already been said by Vani, that the World Pneumonia Day was established by Stop Pneumonia Initiative in 2009 and is observed globally on 12th November every year since then. The day is celebrated to raise awareness, promote prevention and treatment, and produce global action to combat the disease. The day highlights the need for people to stand together and demand action in the fight against pneumonia. And I believe nurses can be and should be at the forefront of this challenge. Pneumonia, as you know, is a very common respiratory infection, which affects approximately 450 million people a year and is occurring in all parts of the world. It's the single biggest infectious killer of adults and children in the world. And particularly people of all ages get affected, but those most at risk are infants and young children below 2 years, adults 65 years and older, and people who have other health problems. So globally, there are over 1,400 cases of pneumonia per 100,000 children, or 1 in 71 every year, with the greatest incidence being in the Southeast Asia region, which is 2,500 per 100,000. So our children are very much at risk of having pneumonia. Pneumonia is also a leading cause of hospitalization in both children and adults. Most cases can be treated successfully, although it can take weeks to fully recover. The others who are at risk include smoking, those who are smokers and use alcohol, and those exposed to air pollution and secondhand smoke. Now, recently, COVID pneumonia has really shook the whole world, and particularly in India. COVID pneumonia is a very severe complication of COVID-19 infection, which we saw. 15% of infected individuals develop moderate to severe infection and require admission to hospital, require oxygen or ventilatory support, and recovery takes a long time, anything between 3 to 6 weeks. Deaths due to pneumonia have increased significantly, almost by 20% during 2020-21 because of the pandemic. And this makes the prevention of pneumonia even more critical now. So lessons that we learned during the COVID pandemic, we saw acute shortage of hospital beds. We saw acute shortage of oxygen cylinders. And we also saw acute shortage of trained health manpower, nursing manpower, people who are capable of handling, providing oxygen therapy, handling the patients on ventilators, and training had to be done. When there was, we saw the horrific experience of so many people waiting for beds, searching for oxygen cylinders, concentrators, anywhere. And it really shook the whole country, in fact, because our infrastructure and our preparedness for handling those cases were very limited. Now, today, newspaper has given the report about Thursday, 11th November, 2021. Delhi wrapped in a blanket of smog. AQI, the air quality index, it's severe at 411. So what are you smoking? The 38 stations that monitor air quality in Delhi NCR, most were found to be in severe category. Severe is more when AQI is more than 400, whereas good is when it is less than 50. And you will be surprised, in Delhi, the highest AQI was 701, Noida 941, Ghaziabad 921, and Gurgaon 631. Can you imagine, when we want to be in the category of below 50, we are above 600, 700, 900. And this is not a problem of few days. When we come from severe to very poor category, we feel happy, forgetting that even then we are in a very poor state. So that has really drawn our attention to the problem of air pollution. Air pollution is the leading risk factor of death from pneumonia across all age groups. So almost a third of all pneumonia deaths are attributed to polluted air, killing 749,200 people every year, combined with household air pollution and outdoor air pollution. So it's the very young and very old who are at greatest risk. You know that children are more susceptible to household air pollution in homes that regularly use chula and coal or wood burning for cooking, heating, and lighting. We know that since 2016, our PM Ujjwala Yojana, they have been giving LPG connections free of cost to the people below poverty line to reduce household pollution. The outdoor pollution, especially from pollution emitted by industries, car exhaust, farm fires. We know that for the last few weeks, we have been struggling with this, and not only this year, every year during this time, and all the campaigns of the government, odd even scheme, and campaign to switch off your car at the red light, and with the Supreme Court order preventing and finding a solution to parali burning, we have not been able to control this situation. It is really the need, it has highlighted the need for clean air. It's really vital. Reducing air pollution will deliver significant benefit to health and the environment. And this word Pneumonia Day, Every Breath Counts, is calling for governments with heavy burden of pneumonia and air pollution to commit to reducing the air pollution related pneumonia deaths by 50% by 2030. How is it going to happen? It needs a lot of preparedness on the part of the government, lot of healthcare personnel, nurses. Nurses need to be trained in strategies for assessing and prevention and management of pneumonia, the vaccinations, lifestyle habits that can prevent pneumonias. The Government of India in the IMNCI has included the management, the assessment and management of pneumonia even at the primary care level. The IMNCI includes pneumonia as an illness and classification of no pneumonia, pneumonia, and severe pneumonia with assess, classify, and treat strategy, which you will be learning later in this webinar. At the nurses at the secondary and tertiary level, they need to be also involved with it, and they have to be able to be to give oxygen therapy, to manage people on ventilator. And that is what is the theme and focus of this present webinar. I hope that the nurses, let nurses be at the forefront, championing the fight against pneumonia at all fronts, whether it is primary level, secondary level, tertiary level in hospital and in the community. I thank you for giving me this opportunity to inaugurate the webinar. My best wishes for the success of this webinar. Thank you very much.
Thank you, ma'am, for inaugurating the session. Like ma'am said, COVID-19 and pollution are some of the major factors that has made the importance of pneumonia to a larger extent throughout the world. Now, I would like to introduce everyone to an eminent personality to unfold the theme of the day. That is Dr. Jyoti Sireen. She is the Dean Faculty of College of Nursing, Maulana Ambala. She has done her Master's and PhD from Delhi University. She has overall 36 years of experience in MSc, BSc, MSc, and PhD nursing. She has achieved persistent of Indian. She is the president of the Indian Association of Neonatal Nursing and certified national trainer for neonatal resuscitation program, integrated management of neonatal and childhood illness, and virtual building program of midwifery and faculty organized by INC and UNFPA. She has participated in international practical training courses on quality assurance in healthcare in Indonesia and SIDA's program in child survival at Sweden and Vietnam. She has done significant published works in her credit and has been awarded T.K. Adrenwal Prize for the best work done in research in Masters of Nursing dissertation, and is also an awardee of President of India's Silver Medal for Academic Excellence in BSc and President of India Gold Medal for Masters of Nursing. She has participated and presented in various workshops at state and national and international level. Ma'am, would you please unfold the theme for the day?
Good evening, everyone. Thanks, Vani, for introducing me to the group. Hearty congratulations to the Indian Society of Emergency and Cardiac Nurses, the entire organizing committee, for taking up the lead to create awareness amongst the nursing professionals regarding Stop Pneumonia, Every Breath Counts. The theme itself, Stop Pneumonia, Every Breath Counts, is very vital in the present context, when in unprecedented time of COVID-19, we have seen losing many lives because of inadequate infrastructure, inadequate numbers of trained manpower, and a lot of panic and havoc was there. Dr. Manju Vatsa ma'am has already shared her valuable insights on the topic and has set the platform that the theme is very apt in the present context. So, may I have the next slide, please? I will just request the organizing team to run the slides, please, from their end. Yes. As it has been said earlier, just to reinforce that we know that pneumonia is one of the biggest killer amongst the infectious diseases. World Pneumonia Day is observed globally as an annual event, and it was first celebrated on 12th November in 2019 by the Global Coalition Against Child Pneumonia. When the campaign was first launched, pneumonia was estimated to be 1.2 million children were dying every year. WHO and UNICEF in 2013 released an integrated action plan to prevent and control pneumonia and diarrhea. Next slide, please. World Pneumonia Day provides an annual forum for the world to stand together and demand action in the fight against pneumonia. More than 100 NGOs representing the interest towards caring for children, preventing childhood mortality, joined forces as the Global Coalition Against Childhood Pneumonia and to hold the first World Pneumonia Day. So today, being 12th November, we are celebrating World Pneumonia Day, and the theme is Stop Pneumonia, Every Breath Counts. So, as said earlier, it's the single biggest infectious killer of adults and children. It has claimed the life of 2.5 million, including 6,72,000 children, and robust efforts are required to fight pneumonia, and which could avert nearly 9 million childhood deaths from pneumonia by 2030. And some of these efforts have already been highlighted by Dr. Manju Vatsa. Next slide, please. Most pneumonia deaths occur in low and middle income countries, and many more are preventable. As Madam said, that children under 5 are at greater risk, or adults more than 65 years of age are at higher risk for getting pneumonia. And all of us know that 1/5 of childhood mortality is still caused by pneumonia in children. And every minute, 2 children under the age of 5 years die of pneumonia across the world. India has the highest number of pneumonias and diarrhea deaths in the world. Uttar Pradesh, Bihar, Madhya Pradesh, and Rajasthan are the major contributors. India ranks second in the world, contributing to 26% of the global burden and 36% of the burden of the entire Asia. So if this is the burden of pneumonia and death, morbidity and mortality related to it, so it is the prime responsibility of the largest healthcare workforce, that we being the nurses, that we should be able to contribute, join hands and fight against this disease, which is preventable. Even though it is preventable and treatable with low-cost medicines, pneumonia still accounts for 15% of death in children. We know when we have the guidelines prescribed by the Government of India in IMNCI, what to observe, what to ask, how to manage these children, how to identify, how to empower the mother of a child with pneumonia so that the repeated attacks of pneumonia do not occur and child does not get repeated hospitalization. Still, 15% of death in children is due to this. All of us know that the primary immunization, proper treatment on time, and adequate nutrition can help prevent the disease. Once we say primary immunization, it is related to pertussis, it is related to measles, as well as the pneumococcal vaccine, which is available. And it has been included in the Universal Immunization Program since 2017. So this should be really enforced so that the deaths which are preventable can be taken care. It is very important that the modalities should be devised where the children can be identified at an early stage and the timely treatment can be given. I still remember way back in 1998 when I went to Indonesia, in every community health center, when the child was coming under the age of 5, they had a stamp on the child's card, health card, and they had to assess the child for respiratory rate, any grunt, which was, or any retraction of the intercostal muscles, which could be easily identified by the nursing professionals or the primary healthcare givers. And this was one of the early identification could help to diagnose it earlier and manage it much faster without much of complications. We know when it is not timely managed, then it can lead to complications. And why adequate nutrition is important? Because when a baby is given adequate nutrition, it will improve the immune process and it will help to prevent the disease. Next slide, please. Yes. So the prime interventions which can be done to stop pneumonia are to raise awareness. Amongst whom? Amongst the healthcare professionals, of course, amongst ANMs, ASHA workers, amongst parents. Because if parents are able to identify the cases at an early stage and they are able to get the care at healthcare facility, of course, the child can be treated. To promote interventions that will help prevent, protect, and treat pneumonia. To highlight the approaches and solutions to the disease and also the need for any additional resources and attention. Therefore, the political commitment, the initiatives by government, organizations, by NGOs, as well as by the international bodies is required to help to overcome this disease. Increase action as well as investment to fight pneumonia and other deadly childhood diseases. Next slide, please. So these are the various initiatives, if these are taken, will definitely have a positive impact on stopping the pneumonia. We know the single most effective strategy for prevention of pneumonia in childhood is primary vaccine. And then we have even the pneumococcal vaccine has been included under the immunization schedule. One has to create awareness, and even the adults who are above 65 years of age should be vaccinated, and adults who have diseases which are immunocompromised, they also should undergo the vaccination. We should raise awareness about pneumonia, which is the world's leading infectious killer of children under the age of 5 years. So who has to be, for whom the awareness has to be created? Of course, the healthcare workers, which are very close to the mothers as well as to the child, that is ASHA workers and ANMs, and the mothers have to be made aware how to identify what are the danger signs, how they can recognize, how they can count the respiratory rate, how they can see for any retractions, and the child should be brought before wheezing and other problems start. Next slide, please. Yes, so protect, prevent, and treat are the three main approaches for combating pneumonia. And we know protection can be by having exclusive breastfeeding, for the first 6 months, for adequate complementary feeding, giving adequate nutrition, well-balanced diet to the child, which will build immunity and fight against the disease. Next is protect, prevent. Next slide, please. And we have said that immunization against Hib, measles, whooping cough are the most effective ways to prevent pneumonia. So vaccines are the best form of prevention of severe diseases like streptococcal infections, measles, and rubella. Regular steps like frequent hand washing, maintaining hygiene, and access to clean water are also important to prevent pneumonia. And Dr. Manjuvatsa has rightly said that the air pollution outside the house as well as inside the house has to be reduced so that a child gets fresh air to breathe, an adult gets fresh air to breathe. And when we breathe fresh air, of course, it will have positive impact on the health. So parental smoking, overcrowding living conditions have to be also considered in preventive measures. Next is the treatment. And we know that the treatment you will be learning in detail in the webinar later on. So, but we know that one study has shown that almost US $109 have been spent are the estimated cost for antibiotic treatment and for diagnosis of pneumonia. And see, this money can be saved if we are able to empower and timely diagnose and treat the patient. And lack of oxygen, which became very evident during the COVID-19 times, as well as there are evidences which have shown that in low-income countries, only 1 in 5 children who need oxygen can be given oxygen. So it is the time when the healthcare infrastructure has to be improved, though significant improvements have been there during the COVID-19 times, but these have to be taken care throughout. Next slide, please. Yes, we have already said, and we know if we delay treatment, it will have negative impact. These factors we are already aware, and we have said air pollution, poor nutrition, low access to vaccines. Next slide, please. Yes, suboptimal breastfeeding, malnutrition, air pollution, and inadequate access to hand washing are the contributing factors for pneumonia. So our prevention strategies and supportive strategies should be dealing with these risk factors. Next slide, please. Yes. So the World Pneumonia Day, Stop Pneumonia, Every Breath Count, is calling on high-burden country governments to take integrated multi-sectoral action plan to reduce air pollution related pneumonia deaths. So again, I would like to congratulate the entire governing body of Indian Society of Cardiac and Emergency Nurses for taking this wonderful initiative and creating awareness amongst the nursing professionals about this disease. Thank you so much.
Thank you, ma'am, for your lovely unfolding of the theme, Stop Pneumonia, Every Breath Counts. Before moving to our next session, I would like to inform all the participants that the feedback forms will be available only after this session, and you will be needing 100% participation for getting the certificate. So with this, now let's move on to our sessions. Now, I would like to invite our first speaker, Ms. Ambli Venugopal. She is a nursing officer in All India Institute of Medical Science, New Delhi. She has done her BSc and MSc in Pediatrics, Imce, New Delhi, and has worked as a lecturer for 1 year in Pal College of Nursing, Halwani, and has been working as a pediatric nursing officer since 6 years in All India Institute of Medical Sciences, New Delhi, and is also a member of Indian Association of Neonatal Nurses. She has won second prize in oral paper presentation in the 7th International CME and has published a research paper in Asian Journal of Nursing Research and Education, and is also a co-author in Target High. I welcome you, ma'am, to give your first presentation on latest guidelines in pediatric pneumonia assessment and management.
Yeah, thank you, Vani. Am I audible?
Yes, ma'am.
Yeah, I will share my screen. Okay, can you please enable me to share the screen? I am disabled.
Enabled now, you can share.
Okay. Yeah, is it visible to all?
Full screen.
Is it visible? Is it visible now?
Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Okay. So a very good evening to all. So let's start our first talk on latest guideline in pediatric pneumonia assessment and management. So pneumonia continues to be the biggest killer of worldwide children under 5 years of age. Although the implementation of safe, effective, and affordable interventions has reduced pneumonia mortality from 4 million in 1981 to just over 1 million in 2013, pneumonia still accounts for nearly 1/5 of childhood death worldwide. In the early 1980s, the global burden of childhood mortality due to pneumonia led the WHO to develop a pneumonia control strategy suitable for all countries with limited resources and constrained health system. So as we all, pneumonia is a form of acute respiratory infection that affects lung. In an individual with pneumonia, the alveoli are filled with pus and fluid, which makes breathing painful and limits the oxygen exchange. So what are the main causative organisms for this condition? Based on the age group. Among the neonatal age group, the organisms like group B streptococci, Klebsiella, E. coli, Listeria monocytogenes, Streptococcus pneumonia, Streptococcus pyogenes, Staphylococcus aureus are the main causative organism. Children between 30 days to 2 years of age, virus is the main cause of organism. It includes RSV, influenza, and parainfluenza virus. And of course, Streptococcus pneumonia also contributes. Among children between 2 to 5 years of age, Streptococcus pneumonia and Haemophilus influenza type B accounts for most of the cases. Children between 5 to 13 years of age, Streptococcus pneumonia, Mycoplasma pneumonia, adenovirus, and influenza virus accounts for most of the cases. So in etiology, as we all know, pneumonia can be caused by several infectious agents like bacteria, virus, fungi, chemical pneumonia, or it can be even aspiration pneumonia. And we are also familiar with the terms like community acquired pneumonia and hospital acquired pneumonia. Community-acquired pneumonia means those pneumonia which is acquired outside the hospital. The pathogens responsible include Streptococcal pneumonia, Haemophilus influenza, Chlamydia pneumonia, Mycoplasma pneumonia. Hospital-acquired pneumonia means the pneumonia which occur in a person after 48 hours of the hospital entry. And if you're looking at the contributing organisms, among the bacteria, Streptococcal pneumonia is the most common organism which accounts for most of the pneumonia among children, followed by Haemophilus influenza type B. Among the viruses, respiratory sensitive virus is the most common cause of viral pneumonia among children. Among children with HIV status, pneumocystic kidney pneumonia accounts for most of the cases, and it contributes about 1/4 of death among HIV positive children. Now come to the transmission. The transmission occurs, the virus and bacteria that are commonly found in child's nose or throat can infect the lung if they are inhaled. And it can also spread via airborne droplet when an infectious person cough or sneeze. Pneumonia may also spread through blood, especially during and shortly after the birth. As we all know, in newborn babies, the early onset of sepsis occur because of the pathogen which are contacted from maternal genital tract or from the delivery area. And it leads to development of sepsis within 72 hours of life, and most often it is manifested as pneumonia among newborn babies. In pathophysiology, the organism which is responsible for pneumonia will gain entry into the lower respiratory tract below the larynx through different mode of transmission. Once the barriers are breached, this infectious organism will colonize and result in inflammation and injury or death of the surrounding epithelium and alveoli. This will ultimately accompanied by migration of inflammatory cells to the site of infection, causing an exudative process which in turn impair the oxygenation. So we will quickly review the 4 stages of low bar pneumonia. They are alveolar edema and vascular congestion, red hepatization, gray hepatization, and resolution stage. Alveolar edema and vascular congestion. This mainly occur within 24 hours of the infection. The microscopic examination shows many bacteria and few neutrophils. In red hepatization, the RBC and fibrin will gain entry into the alveoli, and alveoli looks like red in color, and the consistency is like a liver. That's why it is termed as red hepatization. In gray hepatization, this stage occurs 2 to 3 days later. The lung appear dark brown in color. This is because of the accumulation of hemosiderin and hemolysis of the RBC. The last stage is the resolution stage, in which the enzymes in the lung digest the exudate, WBC fight of the infection, and remaining may be coughed up. The cellular infiltrates are reabsorbed and the pulmonary architecture is restored. If the healing process is impaired, it may lead to parapneumonic effusions and pleural adhesions. Now come to the major clinical manifestations. It includes cough or difficulty in breathing, fever, tachypnea. Auscultation shows dullness with diminished vesicular breath sounds and crepitations, chest indrawing, cyanosis, altered consciousness, stridor, grunting, refusal to drink or feed, and severe malnutrition. So history and physical examination. Whenever a child comes to us with the complaints, we need to take proper history regarding the complaints. Most of the time, the complaints may be non-specific, like lower abdominal pain and all. So we have to take detailed history regarding cough, fever, tachypnea, difficulty in breathing. And important history such as duration of symptoms, exposure history, travel history, sick contact, baseline health of the child, any chronic underlying disease condition, recurrent symptoms, choking, immunization history, maternal health and child health, and any complications, especially in neonates. In physical examination, we need to observe for the respiratory distress, such as tachypnea, nasal flaring, chest indrawing, hypoxia in room air, and SpO2, and inability to tolerate feeds, grunting, apnea, and we have to auscultate for the respiratory sounds. Diagnostic test. How can we diagnose the condition? For diagnosing the condition, we have nasopharyngeal swab assays, complete blood cell count, renal and hepatic function testing, blood culture, and chest X-ray. So we will quickly review the IMNCI management of a child with pneumonia. So the main aim of the IMNCI is to classify disease based on simple clinical signs and symptoms, such as fast breathing, chest introing, and general danger sign. The general danger signs include not able to drink, persistent vomiting, convulsion, lethargy or unconsciousness, stridor in a calm child, and severe malnutrition. So whenever a child comes to the clinic with cough or difficulty in breathing, first question need to be asked is for how long these signs and symptoms are there. Following that, we need to do the physical examination. That is, look, listen, and feel. Count the number of respiration per minute. Then nasal flaring, chest introing. Look for stridor, wheeze, cyanosis. If pulse oximetry is available, check for the SpO2 and check ABPU. That means alert level of the child to the voice, pain, and unconsciousness. Remember, in IMNCI, child between 2 months to 12 months of age, respiratory rate 50 or more is considered as tachypnea. Child between 12 months to 5 years of age, fast breathing is 40 or more breaths per minute. So based upon these clinical signs and symptoms, in IMNCI, child will be classified into any one of the color code system out of 3. These are green, yellow, and pink. So if not enough signs are there to classify it as pneumonia, it is considered as no pneumonia or cough and cold. In that case, mother will be advised for home care, educate the mother when to return to the clinic, treat wheeze if present, soothe throat and relieve cough with safe remedy, follow up in 5 days if not improving, screen for possible TB and HIV infection. In a child with fast breathing, with or without chest introing, it is considered as pneumonia. In that case, child will be given with amoxicillin dispersible tablet, vitamin A, treatment for wheeze if present, soothe throat and relieve cough with safe remedy, follow up in 5 days if not improving, screen for TB and HIV, review in 2 days, if not possible, admit or refer the child with chest introing. Child who is having danger sign or the saturation less than 90%, stridor in a calm child, central cyanosis, the child is not responding to only verbal command or pain or unconsciousness. This child is classified into pink category and considered as severe pneumonia or very severe disease. In these children, parenteral antibiotics such as benzyl penicillin or gentamicin will be given. If SpO2 less than 90, oxygen will be given. Treat and prevent low blood sugar. Keep the child warm. Treat wheeze if present. Admit or refer to the hospital. Screen for TB and HIV infection. So earlier pneumonia was classified in a different type, and now the latest classification is different one. So we will quickly review the differences in previous and present classification. So in earlier classification, child between 2 to 15 months of age with cough or difficulty breathing. If there is no enough sign to classify as pneumonia, it is considered as cold and cough and home care is advised. A child who is having fast breathing is considered as pneumonia and oral cotrimazole and home care advised. A child with chest introing is considered as severe pneumonia. A child with general danger sign is considered as very severe pneumonia, and in both these cases, parenteral antibiotics such as chloramphenicol was given. In the present classification, child between 2 to 15 months of age with cough or difficulty breathing, if there is no enough signs to classify it as pneumonia, it is considered as cough and cold and home care is advised. Child with fast breathing with or without chest introing is considered as pneumonia. So in the earlier classification, only fast breathing is considered as pneumonia. Chest introing child is considered as severe pneumonia. In the present classification, both fast breathing with or without chest introing is considered as pneumonia, and oral amoxicillin and home care is advised. Children with general danger sign is considered as very severe disease, and first antibiotic, parenteral antibiotic will be given and referral facility will be made. So what are the change occurred from the earlier classification to the present classification. So the first recommendation made by WHO was children with fast breathing pneumonia with no chest indrawing or general danger sign should be treated with oral amoxicillin 40 mg per kilogram per dose BD for 5 days. In area with low HIV prevalence, it can be given for 3 days. Children with fast-breathing pneumonia who fail to respond to the first-line treatment with amoxicillin should be option of referral facility where the appropriate second-line treatment is available. Second recommendation made by WHO is that children between 2 to 15 months of age with chest indrawing pneumonia should be treated with oral amoxicillin at least 40 mg per kilogram twice a day for 5 days. In the first classification, in a child with fast-breathing pneumonia is given with other drugs like it is given with parenteral antibiotics. Here in the second guideline, it is recommended to give oral amoxicillin. It is because both drugs, the amoxicillin is found to be more effective in these children with chest indrawing pneumonia. Recommendation made by the WHO is that children aged between 2 to 15 months of age with severe pneumonia should be treated with parenteral ampicillin. If it is not available, penicillin and gentamicin as a first-line treatment. The dose is ampicillin 50 mg per kilogram or benzyl penicillin 50,000 unit per kilogram IM or IV every 6 hourly for 5 days. The dose of gentamicin is 7.5 mg per kilogram IM or IV once a day for 5 days. Ceftriaxone should be used as second-line treatment in children with severe pneumonia who have failed to the first-line treatment. The recommendation 4 is that ampicillin, if ampicillin is not available, penicillin plus gentamicin or ceftriaxone are recommended as a first-line treatment for HIV-infected and exposed children under 5 years of age with chest indrawing pneumonia or severe pneumonia. So only in HIV-exposed and infected children, parenteral antibiotic will be given. In other children with chest indrawing pneumonia, oral amoxicillin will be given to them. For HIV-infected and exposed infant and for children with chest indrawing pneumonia or severe pneumonia who do not respond to the treatment with ampicillin or penicillin plus gentamicin, ceftriaxone is considered as second-line treatment. The recommendation 5th made by the WHO is that the treatment with clotrimazole for pneumocystic pneumonia is recommended as an additional treatment for children with HIV-infected pneumonia, only recommended for children between 2 months to 1 year of age. Children who are older than 12 months of age, that is 1 year of age, the treatment with clotrimazole is not recommended. These are the main guideline changes made by the WHO from the previous one. The adjuvant therapies include fever is managed with paracetamol, infant has to be kept warm, provide semi-sitting position, clear the airway with nasal irrigation and suction, oxygenated flow rate required to maintain SpO2 more than 90%. If pulse oximetry is not available, minimum 1 liter per minute, maintain adequate hydration and nutrition. In children with severe respiratory difficulty, place an IV line and give 70% of the fluid through the IV routes. Resume oral feeding as soon as possible. That means if there is no respiratory difficulty or ability to drink and eat normally. Use nasogastric tube only if IV line cannot be established. And children less than 12 months of age, 5 ml per kilogram per hour. And children who are older than 12 months of age, 3 to 4 ml per kilogram per hour. Resume oral feeding as soon as possible. In the absence of severe respiratory difficulty, breastfeed on demand or milk or food and water by spoon on demand can be started. ORS can be given whenever it is required. And these are my references. Thank you.
Thank you, Ambali ma'am, for such a wonderful presentation. Now, let's move on to the next topic. Now, I would like to invite Mrs. Shakuntala Sundaryal a senior nursing officer in JPNATC, Imce, New Delhi. She has done her BSc nursing from Imce, New Delhi, and is a certified faculty in Advanced Trauma Care Nurse, approved by American Society of Trauma Nurses. She is also a certified faculty for Imce Ultrasound Trauma Life Support courses for nurses. She has been doing regular teaching classes for the ED nurses and regular courses for the Trauma Ultrasound Life Support courses. She has also been doing safety and quality improvement in emergency. Ma'am, would you please start with the next presentation?
Chandala ma'am, please unmute yourself from your side.
Okay, now am I audible?
Yes. Ambli ma'am, can you please off your screen share from your side? Yeah.
So screen,
Just put a full screen mode.
okay, just,
End of screen. The end of, yeah.
is it?
No. Here and the end. Yeah, that one. That's okay.
Okay.
Yeah. Okay. Please share on your video also.
Okay, just,
click it.
okay.
Yeah.
So, fine. So is it full screen now?
Yeah. Just again, please do a full screen mode.
Just a minute. Fine. Is it okay?
Now it's fine. Good.
Okay, fine. So good evening, everyone. Myself Shakuntala, and Vani has already told many things about me. So I'm just today going to tell you, give you a glimpse regarding the ultrasound, which we are already using in All India Institute of Medical Sciences for screening the many kind of emergency cases and along with pneumonia. So we are going to see what is the need of the ultrasound screening, and when it is what are the basics of ultrasound and lung ultrasound, how we are doing to screen the pneumonia. So first of all, I would like to tell you a very important thing, that ultrasound is basically a skill. So you need to learn, and you need to perform ultrasound on the patients, then only you'll be able to take up the skill. So this in this lecture, we should we have to just think that we are only giving you we are just telling you that we can do the ultrasound, we can learn the ultrasound and use this skill with the clinical, along with the clinical data of the patient, and we can use for screening many things along with pneumonia, other things also. But this has to be learned by doing. So now this is the studies which have already been done by the nurses, by the residents, that how the lung ultrasound is important to diagnose and pneumonia, and in many cases. So this the study you are able to see, two studies are there. That so first study is accuracy of nurses performing the lung ultrasound in patient with acute dyspnea. So what result they have found, that nurses can perform with good accuracy. If they learn the skill, they can perform the lung ultrasound which has the good accuracy in diagnosing the dyspnea. And another thing is, during the COVID-19 outbreak, when the patients are overwhelmed, and the nursing homes, they are receiving too many patients, so they perform the ultrasound along with the clinical sign and symptoms of the patient for the referral cases, to check out whether they can refer the cases to the big hospitals, or they can manage in their own nursing homes. This study was done in Italy in 5 nursing homes. And this is one of the study which is done in All Indian Institute of Medical Sciences, point of care ultrasound in COVID-19 pandemic. That is when the patients are directly, we are receiving the patient in the emergency, and we are using this algorithm by one of the important point in this algorithm is the point of care ultrasound. So now we are going to just tell you regarding some basic physics that is actually we should know when we are performing the ultrasound on the patient. So this is how the machine works. The first of all, we need to know that how the machine which we are using, how it is working. So we have, you can see we have the probe, which is the contact of patient with the machine. So this probe is having piezoelectric crystals, which generally provide when the electricity comes. When we on the machine, the electricity comes, the piezoelectric crystals, they develop the ultrasound waves. So these ultrasound waves through some medium, it cannot move in the air. So through some medium, they just, we are putting the jelly on the patient, and from this probe, the waves go to the patient's body. Now, the waves, they move through different mediums, through different speeds. So it just go through the body, and the waves which are coming back, they are picked up again by the probe, and then the images are produced. So this is how this is the principle of the the most I think how the machine work. So next is the same that I have already told you. This is the principle that the ultrasound waves are hitting in the body with different mediums, different body structures, and they are coming back and again picked up by the probe. These are the things, these are a bit technical things, that how the ultrasound waves are moving, with which speed actually they are moving, and how much the our body is reflecting the ultrasound waves. This is basic principle of the ultrasound images, how the images are produced. So you can see, this is a slide. You can see that these are the mediums like air, fluid, soft tissue, fibrous tissue, stones, and bones. So these are the mediums, and these are the waves. So you can see that when the wave is going through a area where air is there, so what is happening? All of the ultrasound waves are reflecting back. The air is reflecting all the waves, but beyond that, what image will come? This box is showing the image which we are going to see in the machine, in the screen of the machine. So this is, you can see that the reverberation images will be seen if the air is there. Then second is the fluid. All the waves are absorbed by the fluid. So you are going to see? You are going to see a black image. Now coming to the soft tissues like our liver, like our kidney, like our or other soft tissues, you are going to see a mixture of the gray color like this, right? And then fibrous tissue, again cartilages, the outer coverings of the organs. So you are going to see that half of the waves are absorbing, half of the waves are reverting. So you'll see slightly white. Only black and white view you will be able to see in the images in the ultrasound machine. And this is last is the bone. So these are very important, that the bones, again, they are going to reflect all the waves. So you are going to see bones in clear white color, but the difference between the air and the bone, you are going to see both as white, but the air, it produces the mirror images. But when it comes to the bone will look pure white, along with there will be no the images and no mirror images behind the bone. So this is very important to know what you are going to see and how you are going to see this. Now you can see just this is the airline. You can see this is the airline. First image is the airline, and the second image is the pleura. You are able to see that these are looking white. See, these are looking white. Pleura is looking white, but with the mirror images. Similarly, air is looking white, but with the mirror images. But you can see the bone is, this is a fractured bone. The bone is looking white, but with the behind the black area will be there behind the bone. So next coming the urine, you are able to see it's whole black. Urine, everything will be, every ultrasound wave will be absorbed, so it will look black. This is the fluid, the blood is there. So this is the fluid again, you are able to see it will be look like black. So these are the probes. We have two probes that is called linear, because the piezoelectric crystals in this probe is placed in a linear way, linear position, and curve linear means it is in a curve fashion. The piezoelectric crystals are kept in these. There are a small difference between these two is the area of usage where you are going to scan, and another thing is the deep. So this linear probe is generally used to see the superficial images. And when you're going to see some deeper images like abdomen and all, you have to just use this curvilinear probe. Now, what is important? See, we have on the keyboard, we have similar to laptop that we have many buttons here. But what all important buttons you need to know, that I'm going to tell you. That first of all, you need to know where the on off button is there, because you have, if you want to do the ultrasound, you have to on your machine. Then you have you should know what are my modes, what are the common modes we are using. And the gain is actually the brightness of the screen, that how much you have to see the brightness, you have to adjust the brightness. Depth adjustment is how much deep you want to see, so you adjust the depth according to that. So these are the ultrasound modes. The two most common used mode are B mode and M mode. B mode is the brightest mode, the most common one. Brightness mode provides structural information in two-dimensional images. And the M mode is basically used where the motions are there, like the pleura is moving. So there you use M mode, that displays the echoes over the time axis. These are the orientation of the probe. Once you put a probe in a longitudinal position, you will see an image like this. And if you put a transverse position, you are going to cross-sectional the abdomen in a transverse way. So you'll be able to see this images. So these are the difference between how you put the probe, longitudinally or transversely. Now we are going to focus on lung ultrasound. So now so generally in lung examination, whenever we are doing ultrasound on a patient, so commonly the patient usually we put supine, and the transducer we are using is the most commonly is the linear. But when you want to see the lower part of the lower lobe of the lung, then you need to use sometimes you need to use curvilinear. Now these are the zones, that is lung zone 1. Lung zone 1, you can see the image, lung zone 1, lung zone 2, lung zone 3. So what intercostal spaces it covers is second, third, and fourth in the lung zone 1, then 5th to 8th in lung zone 2, and lung zone 3 is commonly the lower part of the lung. These are very important signs you need to know. You need to know when you are doing ultrasound, especially lung ultrasound. So the most important is the lung sign. So first of all, you need to put the probe in a longitudinal position. You can see, you have to see how you are going to put the probe. So this is how longitudinally you have put the probe. What you are going to see here, this image will come. As you put the probe over the patient chest in a longitudinal way, you are going to see this sign. So why this is called as bad sign? Because these two, what you are seeing, this is basically the ribs. You are able to see two ribs in between. You are able to see the pleura. Now these are the two ribs, and this is the pleura. This is the pleura, right? So this you need to, whenever you are seeing the pleural sliding, now I'm going to tell you that what is actually the lung sliding. See how you're able to see. See, when you do lung ultrasound, see these are the two ribs and the lung pleura is moving in between the lungs. So you are able to see. So this is how the lung sliding, we generally say it's present or absent, but in presence means it should be present. It's like that. So the lung sign, another, when you are in the moving pleura, when you put the M mode, I have told you previously, the M mode is generally used when the motion is there. So in this lung is sliding, the pleura is sliding. So when you put a mode, this is how you are going to see the image. And this is the confirmatory sign to rule out the pneumothorax. If the lung is sliding is present, there is a presence of seizure sign on the M mode, it means you can just rule out the pneumothorax. Now moving to the other signs that are basically related to the pneumonia. So B lines are similar to the reverberation, right? Reverberation produced by the front and back of very strong reflector. When we have fluid and air interface, the pleura is sliding, but if we have more fluid, more in the interstitial, in the alveoli, in the interstitial space, so the B line develops. These B line, they just develop. See, you are able to see the bright lines, torch-like lines, which we are producing from the pleura and going to till the end of the image. Now pneumonia, Ma'am Ambli has told you in a very nice way that how you are going to diagnose the clinical examination you have to do, and what all the stages of pneumonia. So it is similar, but when you are where you have learned that there is a stage of congestion, there is a stage of red hepatization, there is a stage of gray hepatization, and the last stage is the resolution stage. Similarly, the ultrasound is going to change. In which stage the patient is, the ultrasound will be different. So this is how I'm going to tell you how you're going to see when in which stage the patient will be and how the ultrasound will be. You'll be able to see the ultrasound. So this is how in the stage of congestion, you'll be able to see too many blue B lines. When the next stage, the red hepatization stage, you'll be able to see the tisular pattern. When there is a gray hepatization stage, the pleural stretch line will come. And the last, when the resolution is happening, then the dynamic bronchogram will come. How it will come, I will just explain you. So these are the B lines. So I told you in the stage of congestion, first is the stage of congestion. In stage of congestion, what is happening? There are too many bacteria is there, and WBC is there. They are developing. They are the fluid is there. So all the B lines will be developed. Too many B line will be developed. So this is always related. If the too many B lines are there in any kind of in any lung zone ultrasound, you are able to find the too many B lines. It means the patient is in the stage of congestion. Now second comes the tisular pattern. Tisular pattern, what happens? All the alveoli get blocked. So no airflow. So if no airflow, then the lung will look like tissue. It will look like liver. That's why it is called as hepatization, red hepatization. This is what happens when you are going to do, if you are able to see a lung in the ultrasound. Generally, the lung, you are not able to see the lung. You are always able to see the pleura moving. So if you are able to see the lung on the ultrasound, it means there is a red hepatization state, that all the alveoli are blocked and the lung is looking like a liver, another, right? So this is how you are able to see the lung on the in the second stage. Now coming to the third stage, that is actually the gray hepatization. What is happening in this? In this, that you are recovering from the blocked alveoli, they are opening. So when they are opening, the air is entering in the alveoli. So this is how you see the pleura. See, you are able to see all the pleura is broken, because in some alveoli there is air, in some alveoli there is fluid. There in some alveoli there are air, so air is entering. The recovery is happening, but this is how you are able to see in the third stage. That is, it clinically you say a gray hepatization stage. You are able to see the pleural shred sign. Now see all the pleura is broken up. All the pleura is broken up. See, you are able to see now. Next is last sign is basically dynamic bronchogram. What happens that yes, the recovery, the resolution has happened, the alveoli are opened, but the alveoli are the some of the airs are trapped in between the alveoli. So what happens that you are able to see a area of lung with too many dots. Dots is basically they are the air trapped inside the alveoli. So you are able to see this is last stage, that is resolution, and along with after some time you'll be able to see again the pleura moving. So this you can say, if the patient is able to see, you are able to see the dynamic bronchogram, which means the patient is in the stage of resolution. So this is how we correlate the ultrasound with the ultrasound images with the stages of pneumonia. So first of all, you will be able to see the B lines, then you'll be able to see a tissular pattern of the lung, then you're able to see the shred sign, then finally you are able to see the dynamic bronchogram. So in summary, I must say that ultrasound is a very good diagnostic tool to screen the pneumonia patients, and along with many other things you can do with the ultrasound. And nurses, yes, nurses can learn. It's a skill. If you learn, you do the ultrasound, you can easily able to diagnose with very accuracy. You can able to diagnose and screen the pneumonia patients. So any question regarding this session?
Thank you, ma'am.
Only?
I
Yeah.
don't think presently now there are any questions. I think there is some delay in the questioning because now the participants have questioned mostly regarding the last session with the Ambli ma'am's presentation.
Okay.
Maybe
No
it will
issues.
yours will come bit later.
Yeah.
So
now
yeah, ma'am. When the questions comes, I'll direct it towards you.
Okay. So
thank you, ma'am, for a wonderful presentation. With this presentation, we have learned that a new scope in nursing has been introduced and explored, and it will most certainly will expand the scope of nursing, and as well as improve the quality of nursing care provided by the nurses in the bedside. With this knowledge, I hope every participants have learned not completely but little bit regarding the ultrasound imaging and what all things can be noticed. So thank you, ma'am, for a wonderful presentation. As I said, your questions might be coming a bit later. I'll direct it by that time. Now,
thank you.
Okay, thank you, ma'am. Now we have a few questions from the participants to Ambli ma'am. As Ambli ma'am, are you there? Ambli ma'am? So is Ambli ma'am online?
Okay, we will take it up that question later.
Okay.
Issues with Abli.
Okay. So there were some questions. So now let's move on to our next session, which will be presented by Ms. Shanit Sumesh. She is presenting this from all the way from Houston, Texas. She is an FNP, APN, RN, and CPAN nurse. She has done her BSc nursing from MGR University, Tamil Nadu, India, and done her master's in family nurse as a family nurse practitioner from School of Nursing, Houston, Texas, USA. She has clinical experience of 1 year as a critical care nurse in Kerala, and from there she has after that she went to Texas with 1 year of RN experience in medical surgical telemetry and 9 years experience in post anesthesia care unit UDMDA Cancer Center, Houston, Texas. She is an AHA certified BLS, ACLS, and PLS provider and certified post anesthesia care nurse since 2005. She has published paper in Journal of Peri-Anesthesia Nursing and presented it to ASPAN National Conference in 2017 and GAP International Conference in 2017. She has also done research on cancer in 2021 in UT Health Center, Houston, Texas, and won Desi Award in 2014 and 2019 respectively. She has also been a nominee of Awesome Job Award for exceptional patient care and management. Now I request ma'am to give her presentation.
All righty. Hi there. Can you all hear me?
Yes, Shannon.
All right. I am trying to share my screen today, and let me see. All right. Coming up. Can you all see my presentation right now?
Yeah. Please put a full screen.
Yes, ma'am.
Presentation.
Okay, I will. Yes. Mm-hmm. Is it visible for everybody and I'm audible, right?
Yeah.
Yes, ma'am, you're audible.
All right. Thank you, Ms. Wani, for the wonderful introduction you did. And myself, I am Shannon Sumesh, and I work at the University of Texas MD Anderson Cancer Center here in Houston in the US. I would like to begin my presentation by thanking the Indian Society of Emergency and Cardiac Nurses for this wonderful opportunity to speak about adult community-acquired pneumonia on World Pneumonia Day webinar. So to begin with, my agenda today is going to be over here. I am going to start with presenting some details about a respiratory system, and we are going to go over adult community-acquired pneumonia in the upcoming slides. So let's begin. So we're going to look at the anatomy of the respiratory system over here. And we all know that the respiratory system has an upper airway tract and a lower airway tract. When we speak about pneumonia, this is very pertinent that we understand the anatomy of the lower respiratory system. And in this picture, you can see, hold on, let me hide my screen. Okay, there. I think it's more visible right now. So here, the lower airway system that starts with the trachea, and that is going to divide into the left main bronchus over here and the right main bronchus over this side. And then it's going to break down into the bronchioles and it terminates with the alveoli. The alveoli are these grape-like structures shown in this image over here, and that is where the air exchange happens in the lungs during the inspiration. And pneumonia can happen anywhere between the bronchioles and the alveoli. And another main aspect I want to point out is that the right lung has 3 lobes. It is the upper lobe and the middle lobe and then the lower lobe. And the left lung has an upper lobe and a lower lobe. Moving on to the next slide, I want to point out some differences in the infant airway compared with an adult. Children are small in size, and so is their airway. As shown in this picture over here, you can see an infant's airway is half the size of an adult in anatomy. And the problem happens when there is an edema or an inflammation happens in the airway. A 1 millimeter of circumferential edema in a child's airway can obstruct their airway by 75%. It reduces the diameter by 75%. When an adult airway, for the 1 millimeter of circumferential edema, adult's airway reduces its diameter by 44%. So we can understand what is the main takeaway here. The point is that a pediatric airway do not compensate for an edema or inflammation like in an adult. And that is the reason why pediatric patients are at very high risk for severe hypoxemia. And another thing is that oftentimes the initial sign that you are going to notice in a pediatric patient is a bradycardia. And you may not see the child is turning blue right away, but you can notice bradycardia in a child when they experience severe hypoxemia. Moving on to my next slide, I have a question for the participants here. How often do you listen to your patient's lungs in your practice? Do you listen to your patient's lungs when you take over your shift from the previous nurse? If you don't, I recommend that you start practicing it today. Pick up that stethoscope and practice that skills that you learned in the nursing school. The practice, that is what is going to make you differentiate a normal lung sound when it comes to listening to an abnormal lung sound. Here, we are going to look at the differences in upper airway obstruction sound compared with the lower airway obstruction sound. Can anybody here tell me what is the most common upper airway obstruction sound that you hear in a day-to-day basis? I guess I'm going to go with the point, snoring. So we all think that snoring is a habit. But snoring occurs when there is an upper airway obstruction in a patient's airway. Most oftentimes it's caused by the obstruction of tongue. And in children, the enlarged adenoids and the tonsils can also cause snoring. And another abnormal upper airway sound that is caused by the obstruction is a stridor. And that is usually seen in conditions such as croup, epiglottitis, or a foreign body aspiration or bronchospasm. What we can do to manage an upper airway obstruction is simply remove the obstruction. And how do you do that? For a patient who is snoring, you can provide them with extra pillows to elevate the head of the bed. In case if there is fluid collection or aspiration in the mouth, you can perform a suction. In case of upper airway obstruction, if you can see there is a foreign body that is obstructing the airway, like in a choking scenario, If you can see it, try to remove it and clear the airway, but do not ever perform a blind sweep in a person's airway. If you cannot visualize it, do not put your finger or an object in to remove the obstruction. You might be simply pushing that stuff further down in the airway, and you might be successful at stopping the sound, but only by obstructing the airway by 100% when it was only 50%. So do not perform a blind sweep in an upper airway obstruction. And in case of epiglottitis or bronchospasm, there is an inflammation. In that scenario, a lot of times the patients are going to need immediate pharmacological management, meaning the patient is going to need an epinephrine, like a racemic epinephrine nebulization, or a steroid injection such as dexamethasone IV to reduce the inflammation in the airway. And that is about upper airway. Moving on to the lower airway, the common sounds that we are going to listen in the lower airway obstruction is either wheezes or crackles. And the wheezes are usually seen in case of asthma. And the crackles are heard when a patient is having a lot of fluids in the lung, such as in pneumonia. There is excess mucus that is produced in pneumonia, and also in congestive heart failure. In case of congestive heart failure, there is fluid collection in the base of the lung of a patient, and that is why you are able to hear the crackles. And lower airway obstruction, the patients are going to need treatment, pharmacological management with an albuterol to enhance their airway, to expand their airway. If a patient is having a wheezing or crackles, you are advised not to give a beta blocker that is combined, because in a combined beta blocker, it has a beta 2 blocker, and that is going to constrict the airway and make the constriction more severe. So you have to use cardioselective beta blockers in patients with lung conditions, and that is what is recommended. Moving on to the next slide. Oh, one more thing I want to say. The wheezes or crackles, you are going to need a stethoscope to listen to the lung sounds, versus stridor or the snoring, you will be able to hear without the help of a stethoscope. You can just hear it, and stridor is an emergency. You're going to need an emergency management of the airway. So I'm going to move on to the next slide. Here I have some audio clips attached to the slide, and if there is any glitches, please forgive me. We are going to start with the crackles to begin with. Like I mentioned in the earlier slide, crackles are normally seen, or it's always seen in the lower airway obstruction. And there are two types of crackles. One is a fine crackles, and another one is coarse crackles. It is named after how they sound. So in fine crackles, you are going to hear sound like burning a piece of coal in fire, or if you put a piece of wood in fire. That is exactly how this is sounding like. If it's not clear enough, if your hair is long enough, you can take a streak of the hair and pull it closer to your ear and rub it together. Whatever you hear now, that is very similar to fine crackle. And here I am going to try to play this audio clip, so that will give you an extra clarity on that. I hope you all were able to hear that, and that was fine crackles. And the next one is coarse crackles. It sounds more like a bubbling sound. It happens when there is a lot of extra fluid in the lung. You can grab half a cup of water, put a straw in that, and blow into it. Whatever you hear, that is very similar to coarse crackles. And this is how this is going to sound like. All right, so let's move on to wheezing. And the wheezing is another lower airway sound that you can auscultate, and that one usually happens in case of asthma. And it sounds more like whistling. And this is what wheezing is. And that is an expiratory wheeze. And the only upper airway sound I have added here is the stridor, because I'm pretty sure you all are familiar with snoring. So it is also a whistling sound, and it sounds more like, it's a high-pitched whistling sound compared to the wheezing. This is what stridor sounds like. All right, now we have went over all the common airway sounds. I'm trying to move on to the next slide. It usually causes a glitch. Let me see what I can do. All right, here we go. So we have came down to the topic of pneumonia. Like Ms. Ambali mentioned earlier, I'm not going to go detail because Ambali did give you a very detailed information about pneumonia. Just to revamp, pneumonia is the infection, inflammation, and excess mucus or fluid collection in the alveoli and bronchioles. And that's what pneumonia is. Moving on to the next slide, here I have listed the categories of pneumonia. It includes community-acquired pneumonia, aspiration pneumonia, there is hospital-associated pneumonia, and this is very difficult to treat because the organism, they are found in the hospital, they mutate each other, and they are constantly exposed to a wide variety of antibiotics in the hospital, and they build resistance, and this causes hospital pneumonia very difficult to treat. And another one is a ventilator-associated pneumonia, or we call it a VAP. And this one usually occurs in an ICU setting when a patient is intubated most often. So here we have came down to community-acquired pneumonia in adults, and that is my topic of the discussion. So this is a type of pneumonia that occurs outside a healthcare setting, outside a hospital, outside a nursing home, or a long-term care facility. It has to occur outside a healthcare setting. That is what you can call a community-acquired pneumonia. Patients who are chronically ill in all ages, they are at high risk for acquiring community-acquired pneumonia. And as the patients get older, the morbidity and mortality from community-acquired pneumonia increases in number. Earlier, one of our presenters has mentioned that India accounts for 26% of global pneumonia burden. I think she has probably the most recent because the one that my reference showed 23%. So I just put that number in here, and you can pick whichever one is the latest. So yes, India accounts for 23% of global pneumonia burden, with a fatality rate of 14 to 30%. And that is one reason why it is very important as nurses, we have to educate ourselves and spread information or educate information about pneumonia to the people around us. So here I have listed the causes of community-acquired pneumonia. The most common cause of community-acquired pneumonia is usually virus. And common causes under the virus category, influenza or flu causes most common pneumonia. And nowadays we have the most recent hero who is COVID-19, and we all are aware about it. And the researches are still going on and studies are still going on how to tackle COVID-19 associated pneumonia. There has been a huge number of pneumonia associated with COVID-19, and we have lost a lot of dear ones. And my condolence for every family members and everybody who lost a family member from COVID-19. Anyway, moving on to the bacterial pneumonia. Bacterial pneumonia usually follows a viral infection in the body when your body is immune mechanism is low by a viral infection. And the fungal infections are not very common in people who are immune system is very active. It is usually found in people whose immune system is very down, such as patients who had a recent organ transplant, a patient who is undergoing chemotherapy for a cancer treatment, or a person with HIV or AIDS. Moving on to the next slide, I have given a table here. This is more about bacterial pneumonia, and bacterial pneumonia causes is one of the big reasons why a lot of people get hospitalized for management of pneumonia. Worldwide, it is found to be streptococcal pneumonia is the predominant pathogen that is causing community-acquired pneumonia in people of all ages, followed by atypical pneumonia. And atypical pneumonia is a group of organisms that do not have a cell wall, and it causes atypical signs and symptoms in patients when they get infected. And looking at a person or knowing the history of a person, comparing the signs and symptoms, a lot of times we can come to a conclusion if a person is suffering from a streptococcal pneumonia or a atypical pneumonia. Let me tell you how. So a person is approaching you, let it be an emergency room or maybe in your community. Somebody is telling you that he is having an abrupt onset of fever. Okay, not the point, it's an abrupt onset of fever, and he's having chills, sputum production, and it's associated with dyspnea, fever, cough, malaise, and pleuritic chest pain. Pleuritic chest pain is the chest pain that occurs when you breathe. And this person is coming to you and telling you he's having the symptoms, and you look at the patient, okay, he's about 65 years of age, and he is a person with comorbid conditions such as maybe COPD, asthma, congestive heart failure, or he's having an uncontrolled diabetes, and probably he had a recent antibiotic exposure, or he's alcoholic or immunocompromised, or he's exposed to children, they are going to daycare. In that scenario, it is most likely that this person is suffering from a streptococcal pneumonia. And in older adults, streptococcal pneumonia can also present with confusion, and they may not show a fever because their immune system is weaker compared to an immunocompetent adult. So let's look at atypical pneumonia. A young and healthy adult without any comorbidities is coming to you, like let it be a middle-aged person presenting with signs and symptoms which are very vague. Like in streptococcal pneumonia, the symptoms are very prominent. It's abrupt in onset. But here in atypical pneumonia, the symptoms are very vague. There is a low-grade fever. There is cough, chills, maybe some joint pain and body aches. A lot of times it can be atypical pneumonia. And this type of pneumonia is something you can always see like in a community outbreak, like you get it from a party or going out for a dinner. And this is atypical pneumonia. Let's move on to the next slide now. And how do you assess a patient with community-acquired pneumonia? In the US, we have a system of collecting a comprehensive health history of a patient using a mnemonic, OLD cards, which is OLDCARTS, and each of these letters stands for a word. And O stands for onset. When did your symptoms start? Is it within the last 3 weeks? Is it an acute onset of cough, or it's more like a chronic? And that's going to tell you whether to consider a pneumonia or a COPD. COPD is most likely, it's a chronic condition. If cough will be present more than 3 weeks of duration. And location. Do you feel any pain? Where is the location? Is your pain in the chest? And the duration of the discomfort. How long has the symptom been going on? And C stands for the character. And what is the quality of the pain that you're feeling? When it comes to A, it's alleviating or aggravating factors, which means we need to identify if this patient has taken any medications in the past. We can always go to a pharmacy and pick up maybe a paracetamol or something that's going to help with your symptoms, like a cough drop or whatever. So if a person who is having pneumonia has taken paracetamol and he has taken also some cough drops to help with his symptoms and came to you, are you going to see fever or cough in this patient with pneumonia? You're not going to see it. And that is why it is important for you to identify what they have taken in the past, what does alleviate their symptoms. We need to identify when does the symptoms get worse, what kind of activity make their symptoms worse. Like in case of CHF, congestive heart failure, patients are going to tell you their symptoms are getting worse with their activity. And moving on to R, it is something that is asking you about radiating symptoms. Like in the case of pneumonia, patient may tell you there is a pleuritic chest pain, but it is not going to radiate to your shoulders or to your jaw or to the back of your shoulder like in a cardiac arrest. So T is the timing of the signs and symptom. You need to identify when do you feel the pain. The patient is most likely going to say, when I breathe in, it hurts. That is probably what's going to happen in case of pneumonia. And S stands for associated signs and symptoms. So this way we can acquire, using this mnemonic, we can acquire a comprehensive health history of a patient. Moving on to the assessment, this is the basic nursing principles that we learned in the first year of nursing, which includes inspection, palpation, percussion, and auscultation. During the inspection of a patient with pneumonia, you are going to see tachypnea. Splinting is when there is pain with breathing. The patient would likely not use that side or just hold that side so that he don't have to take a deep breath. Next one is retraction. That is, like Ms. Ambali mentioned, in a drawing of the superficial tissue into the chest. And this is intercostal retractions that is shown over here. And palpation, how do you palpate a person's airway? That is called a technique called, you are going to identify tactile phrenitis. Tactile means touch. You are going to take your hands up and put it on a person's chest. And you are going to ask the patient to say the word 99. When you say that, you can even check it out right now. You can put your hands on your own chest and say 99. You are going to feel a vibration on your hand. And that is what you are looking in case of pneumonia. You have to move your hand across all the lung fields, including the lateral aspects of the lung, and ask this person to say 99 each time you move your hand. If there is a consolidation or fluid collection in a particular lobe, you are going to feel increased tactile phrenitis on your hand. That means increased vibrations on your hand. And why do you feel increased vibrations in your hand? The reason is that the sound of vibrations travels quicker or faster in the liquid medium compared to that of an air. And that is why you feel more vibrations on your hand. And during percussion, solid organs, or if there is a liquid inside the body or a consolidation, you are going to hear dullness, where you're going to hear a louder sound when you percuss on the lung field in a usual basis, in a normal lung. During auscultation, you are going to hear inspiratory crackles or increased vocal sounds in a patient who has pneumonia. Here, we are going to talk about how to diagnose pneumonia. So worldwide, the gold standard in diagnosing pneumonia is a chest radiography, which is a chest X-ray. Do we need a blood culture or a sputum culture to diagnose a patient with pneumonia? No. you do not routinely perform a blood culture or a sputum culture in a patient who is symptomatic. A chest X-ray and the signs and symptoms are enough to identify or diagnose a community-acquired pneumonia or any type of pneumonia in a person. But you will need to collect a sputum culture only if the patient is suffering from a severe community-acquired pneumonia, or this patient is intubated, or this person have an infection of MRSA going on, or if the patient had an antibiotic exposure in the past 3 months. And you also do not need a routine chest X-ray in a patient to monitor their progress during the treatment. You need an X-ray in the beginning to diagnose pneumonia, but not after the treatment routine. You do not need a chest X-ray. And how do we know if our patients need hospitalization or not? And that's where the new guidelines play a role with the Pneumonia Severity Index. And this pneumonia severity index is what decides if the patient needs a hospital admission or not, according to the New American Thoracic Society and Infectious Disease Society of America. And these guidelines were published in 2019. We used to use something called a CURB 65 criteria to decide if the patient needs a hospitalization. So this pneumonia severity index, it has 2 types of criteria. One is a set of major criteria and another one is a set of minor criteria. In the major criteria, there are 2 categories. And if the patient needs at least 1 criteria in the major criteria segment, then yes, your patient needs to be hospitalized. Which is, the first one is severe respiratory failure. In case if you know that the patient is in severe respiratory distress and he is going to need support with the mechanical ventilation, yes, this patient needs to be hospitalized immediately. Or if the patient is in severe shock, who is going to need pressors to support their blood pressure, yes, this patient is going to need a hospitalization. So they have to meet at least 1 out of this 2 criteria for hospital admission. So moving on to the next slide, this is the minor criteria that is listed under the Pneumonia Severity Index. I'm not going to read all of this. You can read it, and I'm just going to tell you that patient has to meet at least 3 or more criteria. If they do not meet the minor criteria, if they do not meet the major criteria, look at the minor criteria. If they meet 3 or more of these criteria, then yes, the patient needs to be hospitalized. Moving on to the next slide, this is a guideline that is published in one of the articles from India. And this guidelines states that if a patient is presenting to an outpatient setting or a primary care clinic with a cough that is lasting less than 3 weeks of duration, and if he's presenting with clinical signs and symptoms such as cough, dyspnea, pleural pain, if there is sweating, they have fevers, they're having aches and pains, a temperature 38 degrees Celsius or greater, tachypnea. Tachypnea is the increased rate of respiration, which is faster than 20 breaths per minute. And they're having new and localizing chest examination findings, then yes, you need to suspect pneumonia in these kind of patients. And what they suggest in India is a chest radiography, just like in the US, you need an X-ray to diagnose a pneumonia if a facility is available. You do the chest X-ray, and if it is suggestive and it found that the chest X-ray shows that there is consolidation, this patient meet the criteria for an antibiotic therapy. Suppose if this person resides in an area where he cannot reach a facility to do a chest X-ray, that's okay. The patient, look at your patient, and if the patient meets a clinical signs and symptoms suggestive of pneumonia, he's having a fever, he's having respiratory distress, you're looking at the SpO2 of this patient, it's less than 90%, then look at the patient and their signs and symptoms, and that is definitely going to tell you if this patient needs an antibiotic therapy. You can empirically treat this patient without a definitive diagnosis. And in India, they also suggest C-reactive protein, and that is an inflammatory marker. This is not specific to pneumonia, though. The C-reactive protein is found to be elevated in any inflammatory process that is going to happen in your body. So it's not specific to pneumonia, but yes, they suggest that you check it. And these are the guidelines currently going on in India, according to this article. Moving on to the community-acquired pneumonia management, and I am going to focus on the current guidelines. These are the most recent guidelines published in the US, and the selection of the antibiotic usually depends on the antibiotic resistance that is found in the locality where the patient resides. And all the practitioners or the doctors, they are aware of the local resistance of the organisms. So here we go by a 5-day regimen of amoxicillin or doxycycline for a pneumonia treatment if a patient ever get diagnosed, and a reassessment follows the treatment. So you need to follow through these patients. We usually educate our patients, if your symptoms do not get better by 3rd day of your antibiotic treatment, please come back to the clinic or please call us and let us know so we can reassess them and we can change the antibiotic if they are not responding to the treatment. And we do not routinely administer steroids to reduce the inflammation. And if the patient is having a comorbidity such as CHF, asthma, or COPD with their pneumonia, we prefer a combination therapy, which includes augmentin or cephalosporin. Augmentin is the bigger brother of amoxicillin, which includes a beta-lactam coverage, which means augmentin is otherwise called amoxicillin and clavulanate. It's a combo, and you can use that one or a cephalosporin. And you need to add a macrolide or a doxycycline with augmentin or cephalosporin. So they have to use a combination of 2 antibiotics. Macrolide is the antibiotic classification that you may know this name, azithromycin, clarithromycin, or erythromycin. That is the macrolide family. And suppose if your patient is allergic to all those antibiotics, you can treat your patient with the respiratory fluoroquinolones. And fluoroquinolones are the family of antibiotics that ends with fluoxetines, such as ciprofloxacin or levofloxacin. And be careful when your patient take this fluoxetine antibiotics because they can cause tendon rupture in patients. If patients come back to you or they report that they're having a joint pain, it's very, oftentimes you will have to rule out a tendon rupture, especially in older adults. So how do we prevent pneumonia? Yes, we all need a virus protection plan like any other software. So here is the prevention, the immunization. Here in the US, there are 2 types of vaccines that are available to prevent pneumonia. And the first one is pneumococcal polysaccharide vaccine. And that one has 23 variants in that one. And it is the first dose of PPSV23 is recommended in every adult who is 65 years and older. And there is another one, which is called PCV13, and that one is a pneumococcal conjugate vaccine. And this is recommended for adult 65 and older who never had a pneumonia vaccine in their life. Or if they have a weak immune system, CSF leak or cochlear implant. Sometimes the physician can ask the patient or recommend the patient that they need a combination of PPSV23 and a PCV13. If that happens, the patient is recommended to take a PCV13 first and then the PPSV23. or if they have already received PPSV 23 for any reasons, then the patient has to wait at least 1 year before they can take the PCV 13 vaccination. So according to the Association of Physicians in India, they recommend that all adults older than 18 years of age in India is recommended to have a pneumococcal vaccine and influenza vaccine. And I am not sure about the availability of this vaccine to the population in India, however. Moving on to the, one more thing I wanted to add about the vaccination. We do have community acquired pneumonia in children. By the age of 2, every children born in the United States are vaccinated with PCV 13, and they get at least 4 doses by the age of 2. And so that way, the incidence of community acquired pneumonia is less compared to many other countries in the United States. And even though they get diagnosed, they do get diagnosed, but if they get diagnosed, oftentimes the treatment is gone by amoxicillin or a 3rd generation cephalosporin. They respond to that most of the time. And coming to the nursing education related to vaccination and also the prevention of pneumonia, we need to practice and we need to teach our patients as nurses to wash hands regularly and clean and disinfect the surface that we use. And we need to cover our cough or sneeze with a tissue. If a tissue or a towel is not available, you can also sneeze into your elbow or use the inner of your shirt just to cover your airway so you don't spread what is in your airway to other people. We need to educate everybody to avoid passive smoking and active smoking. And we need to teach our patient that they have to take their medications on a regular basis to control their asthma, diabetes, and heart disease, because these patients are at high risk for developing pneumonia. So teach, teach, teach. That's our goal, right? Preferably not like this. And yes, that is it about my presentation today. And this time I am open to any questions about my presentation. If anyone has any questions, I'll try my best to answer your question.
Thank you, ma'am. It was a wonderful presentation. I'm getting a very positive response from all the viewers. They are really excited and very happy with your presentation. And
Thank you.
we have a few questions. Like there is a question that, can we treat patients with difficulty in breathing having wheezing sound with azithromycin in case we don't have amoxicillin?
Azithromycin is one of the, it depends. Again, you can, it used to be the guideline here in the US that they were given antibiotics such as azithromycin in the past in the US, and the recent guidelines has been changed to amoxicillin. But yes, you can treat the patient with azithromycin. But wheezing itself, you do not need an antibiotic for wheezing. Antibiotic is usually prescribed if the patient is symptomatic and if they are having an infection going on. During asthma, a lot of times wheezing occur, and we do provide the patients with some albuterol, and that is going to open up their airway, and that is going to treat the wheezing. You do not need antibiotic for wheezing, but yes, if they have an infection going on, yes, you can treat your patient with antibiotic.
Okay, thank you, ma'am. There's another question. How many days we have to give antibiotics to children in case they have pneumonia?
It is a 5-day regimen that we follow right now, 5 days treatment. And we have to follow up your patient. You have to teach the parent of a child, if it's a child, to watch the signs and symptoms. And if the child is not improving in 3 days of the course, 2 to 3 days of the course of antibiotic, they are supposed to reach back to the clinic or the doctor. And if they need a change, we can change the antibiotic regimen for this child.
Okay. There's another question that what happens if a child has pneumonia associated with congenital heart disease?
That question, I will have to get back to you because I haven't researched a lot about pediatric pneumonia at this time, because my presentation was mostly focused on the adult community-acquired pneumonia. But I will get back to you guys with the answer. But oftentimes in children, the preferred antibiotic is penicillin-based, which is amoxicillin. And if they do not respond to the penicillins, then you can use a third generation cephalosporins in the children, and they usually respond to that antibiotic regimen.
Okay, thank you, ma'am. There's another question. At what age we can immunize a child for pneumonia vaccine?
So here in the US, our regimen is that the child is going to get immunized at 2 months. That's where we start. They are going to get immunization at 2 months, then another one at 4 months, and another dose at 6 months. And after that, by the age of 2, they are going to get another booster dose of PCV13. And that is the pediatric immunization schedule here in the United States.
Okay. Thank you, ma'am. There's a question regarding a child developed pneumonia and was on mechanical ventilator. If we notice one side of the chest is slightly retracted as compared to the other side, what is the best step of approach?
So a lot of times if the patient is in the ventilator and you are noticing that the child is not getting air, like the symmetry of the chest is different, that means that there is a problem with the intubation. You need to definitely, as nurses, you need to definitely check if the tube, the endotracheal tube has been deviated from the airway, because there is no way the child is going to have an asymmetry in the lung if the patient is, properly intubated.
Okay, ma'am.
And that is a nursing assessment you have to perform as a nurse at the bedside.
Yes,
because air has to move bilaterally, equally to the lungs if a child is mechanically ventilated or an adult.
Okay, ma'am. There's another question. How can we prevent hospital-acquired pneumonia?
Hospital-acquired pneumonia usually happens when you get, admitted in a hospital. So this is where the prevention comes. You get to the hospital, you get exposed to these organisms, and that is where you acquire. The simple thing is that don't get to a point where you get admitted to a hospital. So you have to watch your hygiene, cover the cough, and probably nowadays you can wear mask and immunization, follow the immunization protocols that is recommended by the physicians. And just best way is prevention of the pneumonia.
Yes, ma'am. Okay, ma'am, there's another question. What is the vaccination for adults less than 65 years of age and the frequency to be given?
So our pneumococcal vaccine guidelines states that you do not have to get immunized unless you have a comorbid condition, or comorbid condition in the sense, if you are a person who is really sick, you need to get immunization earlier at your age. But if you're healthy and you are not having heavy comorbidities, like even with patients with hypertension, we don't immunize them routinely here in the US. You will be getting your immunization at the age of 65 and older. That's when we teach our patients about immunization. But otherwise, children, of course, they are immunized. And if you are your immunity is severely compromised, yes, you can get an immunization at an earlier age. By age of 18, you can get an immunization.
Okay, ma'am. And there's a question that what is the treatment approach if the patient is also a TB multi-drug resistant along with pneumonia?
So here in the US, if you have a comorbidity, like I mentioned in the earlier slide, we go by, a combination therapy of 2 antibiotics. You have to choose either a cephalosporin or an augmentin. And you have to combine that either with a macrolide or a doxycycline. And that is the combination therapy we give. And you have to treat tuberculosis according to the regimen, the DOT and, the rifampin, whatever antibiotic that is recommended for the tuberculosis, the patient is going to need treatment and isolation for that if it's active.
Okay, ma'am, there's another question. Suppose if we are in the community field where referral is not possible due to any cause, so do we have a standing order to administer the drug as per IMNCI schedule?
I am not familiar with the guidelines in India as much, to be honest. And here we do provide referral, but if you're nurses, here in the US, nurses do not have the ability to prescribe antibiotics and treat a patient because they have to be seen by a physician and a chest x-ray has to be taken and it has to be diagnosed. The diagnosis and prescription is the authority of a nurse. Not a nurse, I'm sorry, a physician or a nurse practitioner here in the US.
Okay, ma'am. Thank you, ma'am, for giving us so much knowledge regarding this pneumonia. And it was really lively and a wonderful session. It was very informative. And I think there is no more questions left. I think we have covered almost every question. Thank you, ma'am. Thank you, ma'am, for a wonderful presentation.
You're welcome. And I'm really sorry if I've taken any extra time than the scheduled time. I think I went over a little longer. Sorry about that.
It was very informative and everyone was enjoying it. So it was great, ma'am.
Thank you.
Thank you, ma'am. Okay. Now there is one question regarding ultrasound guide USG to Shakuntala, ma'am.
Yeah, Vani, I'm listening. What is the question?
Ma'am, there is a question that what if the baby is crying? Is it possible to do an ultrasound?
It is always we have to calm the baby. It is the first thing we need to do, and then only we'll be able to perform the ultrasound. Even we can able to understand only when the baby will be calmed down. Otherwise, the baby will not be let you know do the ultrasound. Na? So it is very important to calm the baby first, and then only you just go for ultrasound.
Okay, thank you, ma'am. Thank you so much. I think that's the only question regarding ultrasound. It was really wonderful session. Thank you, ma'am.
Thank you.
So on behalf of Indian Society of Emergency and Cardiac Nurses, I would like to acknowledge our gratitude to Dr. Manju Vatsa and Dr. Jyoti Sireen for taking their time from their busy schedule for enlightening us with their wisdom and presence. And I may also like to express our sincere thanks to Ms. Ambali Venugopal, Ms. Shakuntala Soundaryal, and Ms. Shanat Sumesh on covering various topics of pneumonia. And I hope all the participants have gained a lot of knowledge from this, and this would help them to improve their quality of nursing care to a greater extent. Thank you, everyone.